There you go, sir. We're ready to record.
Very good. Hello, my name is Dr. Michael Parra. I'm a semi-retired hematologist oncologist. Today, we're going to talk about understanding cancer and new technologies associated with the diagnosis of cancer. And with that, let's begin. So, hematology oncology. Hematology is the study of blood, and cancer, or the study of oncology, there are subspecialties of internal medicine. So, typical requirements for typical hematologist oncologists, which again, subspecialists of internal medicine doctor, are a minimum of 4 years of undergraduate degree, usually science background, although there can be other types of degrees you get that they actually look at quite favorably as well too for medical school admission, followed by 4 years in medical school, then 3 years post-medical training and approved residency program for internal medicine, followed by another 3 years of subspecialty fellowship training. In my case, I finished up my internal medicine and medical college in Wisconsin, and then I did my 3 years of subspecialty training at the University of Colorado Health Sciences Center. So oncology and hematology, they're the most rapidly developing and changing fields in internal medicine, and we're going to talk about some of those reasons why now. So what's cancer? What causes cancer? What's the link between genes and cancer, and how we diagnose cancer, and how can we prevent cancer? We're going to talk about all those things. So we know there's different types of cancer. Cancers are unique from the standpoint there are cells with uncontrolled regulation of growth that continue in an indefinite growth pattern, so much the extent which they can actually invade organ systems and cause death by destruction of multi-organ system failures. We actually name cancers by its location and the type of cancer that we see. For example, cancer of the lung is considered a carcinoma. So carcinomas are typically tumors of origin from, for example, lung, which is lung cancer, adenocarcinomas, for example. Breast cancers are carcinomas, colon cancers, bladder cancers. So lung cancer is still pretty high in the number of cancers we see in the United States. Colon cancer is number 2, and breast cancer is actually now number 3. If you look at some of the other kinds of origins of cancers, we name it by origin. So if it's a bloodstream cancer, there may be a leukemia, sometimes acute, sometimes chronic. Lymphomas are cancer of the lymph glands, which are basically filtration systems that we have that filter lymphatic fluids and also are responsible for stimulation of the immune system. Some other types of sarcomas, such as fat sarcomas, bone or muscle with connective tissue, are also unusual types of tumors we see as well too. But those are not quite as common as lung, breast, and colon cancers. Bladder cancer can happen due to smokers and also due to chemical exposure. And prostate cancer is typically a disease of older men. And it's not uncommon for 80-year-old to actually have a degree of mild, very slow-moving prostate cancer on just regular typical biopsy. It's usually a typical, very slow type of cancer. So, naming cancers. We use the prefix in front of the cancer to tell exactly if it's a location within the lung, a carcinoma, and if it's a glandular form of tumor, because there are glands in your lungs, it's called an adenocarcinoma. Same thing for breast, for example, because breast cancers are typically glandular cancers, not from the fatty or connective tissues of the breast, but they're from the glandular sections itself. So a breast cancer can be an adenocarcinoma as well. Chondro is Latin word for cartilage. So chondrosarcoma is a sarcoma from a connective tissue. For the original origin would be, of course, from cartilage. Erythrosarcomas would be for red blood cell production. And hemangiocarcinomas are from blood vessels. They're very rare. Hepatocellular carcinoma of the liver is also a primary liver cancer, which is a glandular form of tumor as well, typically from liver cells. Liposarcomas from fat, lymphosarcomas, for example, or lymphomas from the lymph glands, and melanoma refers to pigmented cells in the skin. So the pigmented cells contain melanocytes, and there's a pigment there called a melanosome. So that's the pigment portion of our skin that we all have. And melanocytes can actually form a very typical type of cancer called melanoma. They're very unusual, and we'll talk about that here shortly, because Colorado has either number 1 and number 2 in the nation versus Phoenix, Arizona for melanomas. A myeloma, which is a primary bone marrow cancer, happens in older people, usually from radiation exposure, changing their DNA of their cells in their bone marrow, a myosarcoma of the muscle, and osteosarcoma, again, muscle and bone origins. So we already talked about the fact that cancer is basically a continuation of abnormal cell growth without the normal mechanism of control. For example, in a normal cell division, if you scrape your skin and there's some cells that come off on your fingernail, your body basically senses that it needs to grow to replace the skin, and it does, and then it stops. There is a normal order of growth, and then your body controls the growth. But what would happen if you had cell damage? That the repair mechanisms of normal cell division are impaired. We actually are all born with oncogenes, which are cancer genes that are turned off, and we actually are born as well too with cancer genes that are basically impair the ability to form cancer as well. So if those are damaged by mechanisms that we'll discuss, then you can have uncontrolled cell division. So again, if you look at the bottom sections here versus the top, cancer cell divisions in the first and second mutations, third mutations become more and more abnormal at the DNA level, causing increased growth, which basically represents uncontrolled growth. And therefore, the danger is spreading to other organs from the original areas. For example, adenocarcinoma of the breast spreading to lung, liver, bones, and brain in that order. So an example of normal growth, as we said, here's a good example of skin cells that are dead, and we shed them all the time. The epidermis beneath is live, and it basically migrates cells to the very top. And we're always taking dead skin cells off all the time. And then the dividing cells in the basal layer continue to replicate those in an orderly growth. The dermis is a connective tissue underneath, along with the blood vessels, the small capillaries, and the arterioles, and the lymphatics. But the beginning of cancer growth could actually happen from skin cells that are exposed, for example, to ionizing radiation. For example, ultraviolet. But what would happen if you damage then that layer of the skin, the epidermis, where the cells there are then actually have DNA damage at the nuclear level? And what happens is then it has this uncontrolled pattern of growth that continues and continues and then invades. And you can see that the basal layer of the skin and the epidermis is now being invaded where the blood vessels are. And of course, if cancer cells invade the blood vessels, your blood vessels go to your lungs, they go to your liver, bones, they go everywhere. So this is the mechanism of cancerous growth occurring within the skin. Other areas in the body, like the lung, the liver, the breast tissue, prostate cancer, they have the same mechanisms as well, but just different locations. So a tumor or a neoplasm won't grow in this particular fashion. You can see then as it continues to grow and go through the basal layer of the epidermis, then invades into the blood vessels and then spreads. So this is early stage cancer in the top, going from to later stage and then to the capability of going to advanced stage, what we call stage 4 disease. So as invasion continues though, what happens is the cancer cells invading the surrounding tissues and blood vessels through the dermal layer, and then they're transported by the circulatory system to distant sites. And then because of the fact they continue to grow, no matter where they go, they reinvade and they grow, and they actually promote their own growth. And I'll show you a mechanism of how that occurs here shortly. So benign versus malignant tumors. So benign tumors, we all have them. For example, moles are benign. They're not cancer. And again, they're cells that grow only locally. They don't spread and they don't invade by metastasis or invasion. Malignant cancer cells do. Again, uncontrolled growth, causing invading a neighborhood of tissues, entering the blood vessels, and metastasizing different sites. So again, that's the mechanism of time. Can you have a benign mole turning to a malignant mole, like melanoma, for example? The answer is yes, with damage. There has to be damage to it, usually to the skin, including sun exposure from ionizing radiation, that over time can actually cause this. It's not a common form of cancer, but it's getting more and more common because of sun exposure and our increased amounts of ionizing radiation from the ultraviolet radiation from the sun. So why is cancer potentially dangerous? Well, spread to organ systems, which it isn't normally there. Like, for example, a melanoma, which can become highly invasive, just a couple millimeters of depth, goes into the surrounding blood vessels, as we just saw, and then spreads from the blood vessels going down through your heart, right side of your heart going into your lungs, and then from your lungs, spreading more cells, going into the left-hand side of your heart and then extending upwards through the aorta, and from the aorta upwards into the carotids, downwards into the lower aorta, involving the upper aortas, of course. The carotid artery will go into your brain, and of course, downward in the rest of your body will go directly into the liver. So this is an example of melanoma cells traveling through the bloodstream. So people talk about the fact that cancer has symptoms. Well, early cancers may not. It's very common for people with skin cancer, and including skin cancers that have nothing to do with melanoma, like squamous cell cancers and basal cell cancers, not to have any symptoms at all. You can actually have early stage lymphoma, early stage lung cancer, early stage breast cancer, and you may have it for a couple of years and not show any clinical symptoms at that time. That's why our screening procedures that we developed so well over the years, initially for prostate cancer and ovarian cancer screening, are very effective in causing cancer to be discovered at early phase. So we want to discover early stage cancer, not late stage cancer. Late stage cancer basically causes morbidity and mortality. In other words, it makes people sick and actually can kill them. Early stage disease can be caught early and actually been, with the advancements in surgery, radiation, chemotherapy, were quite effective now in actually limiting the amount of death from certain kinds of cancers. So colon cancer screening. So by the use of a colonoscopy, which is basically an invention of a flexible tube that is then inserted all the way from lower intestine upwards and all the way to the bottom of your small intestine, we can actually visualize the inside of the intestine. So I had mine done approximately 3 years ago, and I was sedated. I was awake but sedated, and mine was perfectly fine. But if we can find early disease by actually seeing changes in the inside of the intestine to what we call polyps, benign masses that can change into malignancies, we can remove the polyps before they become malignant. You can also do occult blood testing as well too for blood in the stools. It's not quite as accurate because a colonoscopy is a direct visualization. We'll see an example of that shortly when we look at two different patients with early stage and late stage colon cancer. So if we did see something in colonoscopy, visualized it, we could actually biopsy it by a small little forceps. Actually goes right down to the scope, the endoscope that we're using that's flexible. They take a little bite out of the tissue and it comes back, and then we take it to our pathologist, which is a physician that's skilled in the evaluation of tissues of origin of the body by looking at what's called a histology, looking for abnormalities associated with rapid tumor growth, which do show on a microscope and do show on a slide. So they'll freeze the tumor and they'll prevent it from actually growing at all, freeze it in place. They'll take a look at it, and then we can also do what's called a proteomic file. So we know that profile of patients that have malignancy, the tumors sometimes express unusual proteins, so we can detect those. So for example, CEA, carcinogenic antigen, that can be shown with different types of adenocarcinoma. Some cancers, like breast cancer, and other forms of tumors like lung cancer, have genetic changes. So we can do what's called a genomic profile to look for specific markers that we can use for targeted therapy. So if you look at TV and watch some of the channels, look at some of the commercials, you're going to see some of the examples of targeted therapy that actually we're using in cancer today. So a pathologist is going to look at the microscopic appearance of the cancer cell to make the diagnosis. So he's going to look for any signs of change versus normal cellular division versus cancer changes, including a large number of irregularly shaped dividing cells. So in other words, you can actually have, because DNA is more rapidly dividing in the cell with uncontrolled growth, the nuclear cytoplasmic ratio is abnormal. So typically what happens is the nucleus that contains the DNA of the cancer cell is larger than it should be in comparison to a normal cell, as you can see in the top figure. And because of that, the cytoplasm of the cancer cell is pushed off to the side, so it has a small cytoplasmic volume in comparison to a regular cell. And of course, the variation in cell size and shape because the cells are more rapidly dividing. It's not normal cellular division. So you do have loss of specialized cell features. In other words, some types of tumors, for example, of the lung, the glandular portions of the lung don't look glandular anymore. They look pretty wild looking, they look invasive, they're invading into blood vessels, they're invading into connective tissue. So that's called disorganized arrangement of cells. And of course, with poorly defined tumor boundary, Because if they are invading surrounding structures, by definition, it is a boundary change. So we want to see carcinoma in situ. So carcinoma means cancer in place, in sight. So skin cancer, for example, is a good example of if catching cancers in place before they become invasive, penetrating the basal layer of the skin, for example. So you can see that normal cell division is on the left. Hyperplasia means that there's more cellular division, normal division, but more than you should see. Mild dysplasia with the nuclei are abnormal. Cytoplasm is small, irregular outline that continues, so that now patients go from mild dysplasia, which is nothing but a cellular change, to true carcinoma in situ. Actually, carcinoma in situ in the skin, we can cure very easily by excision, complete excision. Sometimes with early skin cancers, you could use liquid nitrogen. And there's even some new drugs we're using nowadays for more invasive disease. We don't want to see cancer become invasive. That's the whole goal. Catching cancer in situ is important. Same thing for example, cervical cancer, catching that before it becomes invasive and invading through the cervix into the surrounding blood vessels, nerves, veins, and lymphatics. Why is tumor grading important? Grade has to do with the degree of irregularity, the degree of how fast cells continue to grow a sign in an abnormal fashion. The pathologist can actually grade that. And why is that important? Because low-grade tumors, cancers that have a lower rate of cell division, have a less wild appearance on the microscope, less ability to invade surrounding structures, for example, have a better prognosis overall. High-grade tumors, tumors that have a more aggressive appearance, faster periods of amount of growth, active mitosis within the nuclei, you can see on the pathology examination, cells that are invading into basement membranes, invading into surrounding organ systems, into blood vessels, arterioles, capillaries, for example, are considered high grade, and high grade tumors have a poor prognosis. Again, trying to find cancers at an early stage. So that's important because staging has to do with the amount of disease either present either locally, regionally, or systemically. For example, stage 1 disease is located just locally. Stage 2 disease may be involving locally and regionally around an area. For example, if you had melanoma involving your skin of your upper chest and you had positive lymph nodes, that's more advanced stage disease. It's not stage 1 anymore. And those patients have a higher degree of cancer spreading, and therefore their 5-year survival rates for patients with melanoma by stage are worse the more advanced the stage. Again, stage has to do with degree of spread. Stage 4 disease, spread, basically metastasis, is the worst prognosis. Again, with melanoma, we're trying to catch it at early stage, as we do with all cancers. So, what causes cancer? So we know that there's some chemicals, and we'll talk about those, some viruses and bacteria that basically cause changes at the DNA level, and there's also radiation as well. But there's other things. We can be born with cancer genes, as I said, so genes that basically are called proto-oncogenes that are turned off, and genes that inhibit cancer genes that are turned on. We know that our diet's important, and we'll show that shortly with some evaluation of population from Japan versus the United States. And there's also some hormonal changes as well, too, that actually stimulate cancer growth. So population-based studies are interesting. So if you look at, for example, different areas of the world, lung cancer is very high in the United Kingdom. Their smoking rates still continue to be very high, including areas around China that have very high rates of smoking. 50% of all the men there smoke. So smoke, direct carcinogen effect, basically changing the DNA level of the cells inside the lung, causing an adenocarcinoma or a large cell or a squamous cell cancer. All those are cancers of the lung. So UK, high lung cancer occurrence because of cigarette smoking directly. China has a higher degree of liver cancer because, for example, hepatitis B can become chronic active hepatitis B, which can affect your liver. That chronic inflammation in your liver from hepatitis B appears to change the DNA of your liver cells and therefore can cause liver cancer. And it's an endemic problem because if you develop chronic active hepatitis CB or C, for example, those increase the risk of developing liver cancer. Japan has a higher incidence of stomach cancer because of dietary change. So it isn't just for example, chemical exposure, ionizing radiation, smoking. There's other things you can do in your diet that can increase the risk of developing cancer as well. In the United States, our risk of colon cancer is much higher than the rates of stomach cancer, again, which we think is dietary in nature. Canada has higher rates of acute leukemia and chronic leukemia because they have higher amounts of endemic radiation in their soils. And we think potentially that increases the risk of developing leukemia, which, as you remember, is a blood type of cancer. Brazil has higher amounts of cervical cancer because of HPV, human papillomavirus, due to increased amounts of sexual contact associated with damage to the cervical surface associated with the increased risk of DNA changes. Australia has high amounts of skin cancer, both melanoma and squamous cell cancers, as well as basal cell cancers, because on the equator, the amount of ionizing radiation exposure from the sun is quite high. So, and again, Denver, Colorado, because of our altitude, we come pretty close. It's not quite as bad as Australia and Queensland, but it comes close. So ionizing radiation from the sun can cause DNA changes, both within the melanosomes, the pigmented cells of your skin, as well as the typical epidermis. Again, this is our changes, physical changes that can happen either due to dietary, chemical exposure, sometimes radiation from the surrounding soils, and sometimes viruses as well. If you look at heredity versus behaviors versus other factors, we can actually look at migration studies. So if you look at, for example, at the graph on the left, you can see that colon cancer, if you look at number of new cases per 100,000 people, compare against Japan versus families migrating from Japan to the United States and versus the regular United States. You can see that colon cancer in Japan is actually pretty rare. But if you have families migrating from Japan to the United States, the risk of colon cancer starts coming up to ours. But if you look at stomach cancer has a very high rate in Japan, a lot higher at 70 per 100,000. But if you have a family migrate from Japan to the United States, they drop their rates because the dietary changes occur here are not the same dietary changes they have in Japan. So it just goes to show that migratory changes in population change their behaviors, including diet as well. And sometimes other things too, including smoking. So smoking. There are lots of cancer-causing chemicals in tobacco smoke. Do not think the fact that now we actually have filtered cigarettes and cigarettes that, have menthol and a whole bunch of different things now are out there. It's still tobacco. The difference between what we had 40 years ago and what we had now is just the degree of chemicals. They're not quite as much because the concentration to make sure that tobacco leaves don't have quite as much. But the truth is, you can see all these are carcinogens. All these increase the risk of developing lung cancer, cancer of the mouth, tongue, because the fact these carcinogens are absorbed in your bloodstream, increase the risk of bladder cancer. Some people think they increase the risk of breast cancer as well. So again, systemic and local exposure to carcinogens causes localized and sometimes diffuse DNA effects, increasing the risk of developing neoplastic cancer growth. So, secondhand smoke. Several years ago, there was a thought that potentially that secondhand smoke was not that damaging. Well, as it turns out, it is, because if you're around somebody who's smoking enough, you're literally breathing their air. And they're not absorbing every bit of the carcinogens whenever they take a deep breath on a cigarette. They're exhaling a significant amount of them. So now we know that actually that secondhand smoke risk, it actually happens at a pretty young age. So it increases the risk of heart disease, lung cancer, and sudden infant death syndrome as well. So it appears that any amount of secondhand smoke is a threat to anyone. So the recommendation would be that if you're around secondhand smoke, if you possibly can, don't be around it. For certain, do not expose your kids to it. And you should consider limiting your exposure as well. It's not good and it's dangerous. But let's say that, for example, you are a cigarette smoker. You start in high school, heaven forbid, because you really shouldn't. And you decide to stop. Is that a good thing? The answer is yes. But the problem is the damage to your DNA occurs over a long period of time. It may take a long time before you actually develop lung cancer. Sometimes there's as much as a 20-year lag between smoking and lung cancer. But it doesn't mean you shouldn't stop because, again, that period where the lung cancer risk goes down occurs over several years, but it does happen. So it's worthwhile still to stop smoking because you can see here from the time periods we've been monitoring lung cancer, looking at cigarette consumption, as it goes up, there's a lag time where lung cancer goes up as well. And as it turns out now, more women are getting lung cancer than men for the very first time. So there is an issue there with more women smoking than ever before. And a lot of reasons, including decreasing anxiety, it controls appetite, some really nasty things for the price you pay. The risk of developing emphysema and primary lung disease, and also developing things like asthma, for example, go right up. And they're substantial. They kill a lot of people just due to primary lung damage from COPD, chronic obstructive pulmonary disease from smoking. So if there are any young women out there smoking, my advice is don't. Men too. So let's talk about what we see with lung cancer. So this is a chest x-ray. So a chest x-ray is basically using radiation, small amounts, to look at density changes. So this actually is a x-ray where we changed the density. So that densities appear to be dark purple blue, and lesser densities appear to be lighter blue. So you can see that the lung contains large amounts of air, so it's not dense at all, hardly. So it appears white on this particular representation. And again, this is a change in a routine x-ray. Regular x-rays look almost like a gray blue instead. So you would expect to see, because lung cancer is uncontrolled cancer growth within lungs, which are primarily air, if you see that, you expect to see a density change. And this particular patient has classic stage 3 lung cancer growing around the edge of his heart, into blood vessels, and surrounding areas of lung. So when you have a patient like this is very common to find stage 3 and stage 4 because they don't have any symptoms right away. As I said before, symptoms don't always show with advanced cancer, unfortunately. So what would you expect to see in someone's lung? This is a good example. On the left is an example of healthy lung. You can see that, there you can see the fissure of the lung. That's normal. That's normal division in the upper and lower lobes. These bronchial tubes staring out at you like little eyes are actually the areas of tubules that pass air from your mouth into your lungs, where you can exchange oxygen and exchange carbon dioxide, which is a primary function of the lung. And you can see the red portions are areas of blood vessels in the lung, and you can see it looks like there's some tiny hollow areas because the lung is primarily filled with air. But what happens if you destroy it chronically by cigarette smoke that increases the risk of developing chronic obstructive pulmonary disease, which destroys elasticity of your lungs, causes bulla, which basically are air bubbles in your lung. You can see on the outside of that happening, but also in the very center of the picture on the right, there's a whitish mass, primary lung cancer. So as you can see, this is an autopsy photo of a patient that died of advanced lung cancer. And you can see the white areas coming down from the original tumor in the very center, extending downwards into the lungs, into the lower sections above the diaphragm, again, showing contiguous spread of disease, invading blood vessels, invading normal tissue, the typical advanced lung cancer that invades by surrounding tissues. And this is a classic case of lung cancer. The thing you want to avoid, if you stop cigarette smoking, potentially that might help out significantly, even if you stop after many years of smoking. There's a substantial thought that marijuana smoke may contain carcinogens as well. The problem is we're learning more and more about it, and some people's smoking habits of marijuana is completely different than others. As you know, marijuana is legal in Colorado at this point. The truth is, though, that besides being a gateway drug, we have some potential issues with carcinogen exposure. They may happen, and you don't know until after 30 or 40 years. So, for the most part, do I think marijuana is a good idea? No, for a variety of reasons. But there is some evidence that you may expose your risk of carcinogens as well. So we know that carcinogens, like cigarette smoke, can increase the risk of lung cancer, as well as other kinds of cancers as well. What about radiation? So we talked about the fact that Australia has a very high amounts of skin cancer, and so does Denver, Colorado. So if you think about it, how does that happen? Because ultraviolet radiation is ionizing. So ionizing radiation causes the release of free ions that cause basically a damage of the DNA. Ions shoot right through the nucleus, damage double-strand DNA, and cause either single strand or multiple polymorphisms of the DNA strands. And remember, those DNA strands are important because they regulate cellular reproduction at a normal rate. So what happens if you damage an oncogene or damage the gene that's shut off? That's shutting off an oncogene. So that means the genes that normally would be used to normally turn off a gene inhibitor gene are now damaged and they can't do their job. And now the oncogenes turn on. So that's a good example of the fact that ionizing radiation can increase the capability of developing uncontrolled cancer growth because it can affect the normal cellular replication and the normal repair mechanism of DNA as well. So Detroit, which doesn't have as much annual sunshine as Pittsburgh and Dallas, if you look at the amounts of skin cancer incidence, it's directly associated with annual sunshine and therefore UV radiation, which is not ionizing low-strength radiation. What about high-dose radiation? What about, for example, uranium? So we know for a long period of time that uranium, again, has ionizing radiation, but more penetrating. It's higher amounts of penetration to the DNA. So potentially it can affect deep organ systems like your bone marrow. So your bone marrow contains cells that basically are called stem cells that basically configure themselves into more advanced stem cells that for white blood cell production, red blood cell production, and platelet production in a very simplistic way. So if we can affect cellular replication of the stem cells, potentially those stem cells may lose the ability to regulate their own normal DNA division and then turn into a leukemia, which is a cancer of the white blood cells. So if you look at areas of the world that have high strength radiation, for example, a good example is uranium miners. Uranium miners are chronically exposed to high amounts of radiation because uranium is an ionizer. And if you look at people that have the most exposure, X-ray radiation as well from the atom bomb will also do it since it's ionizing radiation. So if you look at people from Hiroshima and Nagasaki from the 1940s and look at the risk of developing leukemias and lymphomas as well too, that the higher amounts of high strength radiation exposure you have, the higher amounts of an incidence of leukemia and lymphomas. Again, high strength radiation causes ionization and damage to normal DNA replication as well. Can viruses? You bet. There are a lot of viruses, unfortunately, that are out, and we're going to talk about a classic one that occurred in the 1980s that we didn't know a heck of a lot about when we first actually determined that there was this unusual viral syndrome that was causing problems with weird secondary infections of individuals, chronically damaged immune systems. It was occurring in IV addicts, people potentially with homosexual behavior as well. And we called it HIV initially, and also known as AIDS. So the HIV virus, human immunodeficiency virus, is very weak. And when it's within someone's system by direct exposure, potentially it can actually invade into the DNA of the cell and change the ability of the nucleus to regulate itself. So a good example is Kaposi sarcoma. Kaposi sarcoma is extraordinarily rare sarcoma. Remember, sarcomas are cancer of the connective tissue. They occurred primarily in older Mediterranean men. They're very rare normally, but we started seeing large amounts of them in the late 80s and 90s. And it turns out that without disease, Kaposi sarcoma is pretty rare in the average adult. With HIV infection, it depresses your immune system by affecting the DNA of not just your regular cells, but also your bone marrow as well, affecting what we call T cell function. And because of that, Kaposi sarcoma HIV infection can then diminish the capability of your normal DNA to suppress a cancer gene that should be turned off and develop Kaposi sarcoma. And this is what it looks like. So in an uncontrolled HIV patient with AIDS, acquired immunodeficiency syndrome, this is confluent over the skin in many areas of the body. So if you control the HIV and prevent DNA damage and replication of the HIV virus present within the nucleus of the cell, this can get better. And matter of fact, now because of what we're doing with the antivirals, we can actually control HIV infections quite nicely and make them quiescent. The HIV virus doesn't ever completely go away, but we can control it. But a good example of the fact that an HIV virus can replicate itself within the immune system of a patient and cause secondary cancers that are uncontrolled because you lose regulation. Can bacteria also cause problems with cancer? And the answer is yes. So Helicobacter pylori, we used to think that potentially in the 80s it was a commensal organism, bacteria found inside of your stomach. It was a bacteria that could survive acid growth, believe it or not. But the weirdest thing we found out was associated with ulcers, and some patients started developing increased incidence of stomach cancer. So now it's not just the fact you can treat an ulcer, you can also treat H. pylori with antibiotics if you determine on an endoscope a tube going all the way down the mouth into the stomach. And if you biopsy it and see the Helicobacter pylori bacterium, you can treat that with antibiotics and diminish the chance of stomach cancer later in life. So there can be some direct bacterial change of DNA as well too. It's not common like viruses are, but it can happen with specific kinds of bacteria. So the longer you live, the more chance is that you're going to be exposed to carcinogens or ionizing radiation, such as the sun. So therefore, there's increased risk of developing cancer with aging, particularly breast cancer and colon cancer. Colon cancer, because of the fact that in the United States, our dietary changes may increase the risk of developing colon cancer later in life. And if you're alive long enough to eat those abnormal diets, potentially you can increase the risk of colon cancer. Breast cancer, because of the fact that we think the changes that occur within the breast cancer, within the breast tissue, which is normal glandular tissue, seem to be over a chronic period of time. And therefore, an 80-year-old has a higher chance of getting breast cancer than a 20-year-old without genetic changes. So again, breast cancer can go up with age because of the chronicity of change to the potential DNA of the host tissue, in this case, the breast, and also with the colon as well. So again, is this a high frequency? No, it's not. You can see by age 80, the risk of developing, for example, breast cancer in this particular graph is only about 250 per 100,000 people, which is extremely small. But it does go up in comparison to 20-year-olds. And same thing with colon cancer, going all the way to approximately 350 per 100,000 people by the time of age 80. So is it a good idea to do screening techniques, for example, a mammogram, on a routine basis past the age of 50, and some people even consider even earlier than that, depending on family history, to basically screen for early stage breast cancer for early intervention, and colonoscopies from the age of 50 on, definitely past the age of 60, where you're basically looking at abnormal polyps or abnormal tissue, biopsying it, and then removing it internally if you do see an abnormality. So screening techniques are important for colon cancer, breast cancer. Because of the fact our mammograms have gotten so good, our risk now of cancer-related deaths of breast cancer has leveled out over the past several years, and actually gone down a little bit because we're picking up ductal carcinoma in situ, which is the earliest form of breast cancer, and taking care of it early with early surgical intervention. We've developed techniques nowadays where you don't have to do big surgeries on patients anymore. So we've revolutionized the ability to pick up early stage breast cancer by screening technique. Colonoscopies save lives. You can pick up colon cancer early stages. So heredity in breast cancer. Can you carry genes that have nothing to do with proto-oncogenes that are turned off and inhibitor genes that are turned on? I mean, can you actually carry other genes? And the answer is yes. So in breast cancer in particular, about 5% of all cases are secondary to hereditary gene that you're carrying. You can pass on it's considered X-linked, which means you can pass it on from X chromosome from women to men. Men don't carry the breast cancer disease, but they carry the gene. They can pass on to the daughters. So if a mother has that gene, she has a 50-50 chance of passing on to her daughter because she passes on one of her X chromosomes. She's got a 50-50 chance of passing it on to her son as a carrier, and he can carry it. So by doing background genetics, familial genetics, and histories, we can determine if patients may be positive for what's called BRCA1 or BRCA2, which are the genes specifically associated with hereditary breast cancer. So why is it important? Because those genes seem to increase the risk of developing the changes we talked about within the DNA. So again, is there viruses, radiation, chemicals, hereditary that play roles in development of cancer? The answer is yes. Okay, and again, they have to do with specific areas of the chromosome in the range of the patients with BRCA1 and BRCA2. And again, if we can determine that, there's a simple blood test we can do. Kayleigh McEnany, who is one of the President Trump's press secretaries, has this in her family. They knew she had it. She already had, as a young one, already had interventional surgery where she had her breast tissue removed. She had reconstructive surgery, and she's having her children early in life so that she can then have her ovaries removed, because the positive gene that she carries also increases risk of ovarian cancer as well. So taking out her ovaries at the proper time would diminish the risk of developing ovarian cancer dramatically as a genetic effect. So again, it's important for us to determine if genes are playing a role. It's not common, but it can happen, and we need to be aware of it. So if cancers tend to be involved in multiple mutations, and benign tumors basically can grow occasionally into malignant tumors with time due to mutations. So the multi-mutation therapy says that potentially it may be ionizing radiation, chemical exposure, and it could also be some primary genetics involved too, where again, proto-oncogenes mutate the oncogene turned on, and the mutations that you get due to DNA damage inactivate DNA repair genes that basically turn off cancer cells. And so maybe the mechanism what's considered the multiple mutation and multi-hit theory for the development of cancers. In other words, it may be multiple factors that may be involved in many people. So this is an example of an MRI scan in one of my patients. And if you look at the left photo is basically looking at not breast densities, but it's looking at tissue changes. Magnetic resonance imaging basically uses high density magnetic radiation, where it literally flips the atoms of your body in a microsecond and then it lets them go. And the magnetic fields you generate from that microscopic period of time where the magnetic fields are actually changing the tissues of your body harmlessly, you can actually detect if tissues are present in the body that have their own abnormal magnetic signature. So in this particular case of this patient, we're looking at it from a side view of her left breast. And you can see that her tumor is involving the whitish areas. It's this white, very dense area that you can see in the very middle. And it's got these little spikes to it where it's invading surrounding tissue. But if you then look at the right picture is taken from above, from what we call anterior or superior inferior. So we look at superior inferior from looking down from the top of the body all the way to the bottom. So the top figure where the dense white is the armpit. Give you some idea. And you can see that there's positive lymph nodes present right there. There's a good example of the fact that breast cancer does involve stages of disease. And this patient has stage 3 disease, where cancer spread initially from the very center of the chest, now extending out to the lymph nodes. Again, regional involvement. This particular patient had what's called neoadjuvant chemotherapy to diminish the amount of cancer cells present in the breast, to allow surgery to commence safely and effectively, and she's alive and doing well at this point now, many years later. So screening techniques are important for us to determine cancer, hopefully at earlier stages. So again, this patient didn't have her screening procedures done on a routine basis. Potentially screening is important for this patient to develop breast cancer before it spreads your lymph nodes and potentially avoiding spread elsewhere in the human body. So breast cancer, can we see that some women have increased risk of breast cancer because their breast cancer basically modifies its behavior and its ability to grow? HER2 gene is a good example. So about 25% of breast cancers actually have this particular protein. It's actually an extracellular receptor that the cancer encodes, and it basically allows for stimulation of its growth. So it actually has what's called autocrine regulation. It's able to actually regulate its own ability to grow. Very few of our cells have the capability of really doing that and actually turning themselves on and off, on and off. Usually it's something else that does that. But cancer cells can do it more effectively. So we know that untreated patients with HER2 positive breast cancer may be less likely to respond to certain therapies, and they may be more likely to have a recurrence because of this mechanism of an extracellular trigger, so to speak. So if you look here, you can see what's happening. You can see that the patient has an extracellular membrane protein, HER2 receptor. You can see on the left, if you don't block it, what ends up happening is it tells the cells to grow and divide more rapidly into more cancer cells. You can see the extracellular membrane, the matrix of the lipids, and you can see the proteins as well too. But again, if this cancer receptor for breast cancer in particular, and some forms of stomach cancer, if these are basically left unchecked, this is exactly what they do. They grow better, and therefore they have a chance of becoming more widespread. However, we developed a medication called Herceptin. Herceptin basically blocks the receptor, the extracellular membrane receptor, the HER2, and it prevents the cancer cell from turning on. And then what happens is, because it basically covers over that receptor, your immune system can actually recognize it and actually form a defensive mechanism so that your own body can actually come and gobble up the cancer cell. That can happen. Okay, so Herceptin attaches the HER2 positive cancer cell and tells your body defense system to target, and that's what it does. So it's an effective mechanism. We often combine this drug intravenously with typical chemotherapy, different forms of therapy for breast cancer patients that carry this, if they have more advanced disease, to eradicate cancer cell spread in the body effectively. And this has actually been in therapy now for approximately 15 years. Been doing this for a long time. A good example of the fact that if we can stop the cancer cell from growing by blocking HER2/neu, the extracellular receptor, white blood cells can come and start destroying the cancer cell. You can see in the lower picture that the cell with these spiky little footprints is a cancer cell, what's basically trying to spread. So this cell is actually literally trying to grow in areas. But now the white blood cells see it, these little tiny round blobs you can see on the right, they're basically attaching to the cancer cell when normally they would not have, and they're literally eating it. So if we can block that HER2/neu protein on the extracellular receptor, tumor cells can be killed more easily with chemotherapy, and patients can survive the cancer. So colon cancer. This is a good example of the fact that, again, colonoscopies can detect cancer at early stages to save lives. So this is a good example of the fact you can see polyps, which are basically abnormal to normal size growth of benign tumors. This is a good example of a benign tumor. It's been biopsied, and you can see it. It's kind of growing out from the surface of the intestine, coming outwards into the picture. It's a little irregular appearing because it's not really round, it's not even, it's not symmetrical. Okay, but this particular patient had a benign mass that basically was removed. They would remove ones that look really typical so that this doesn't happen. So this is a good example of a colon cancer, true colon cancer, that has invaded into the surrounding bowel. This is advanced disease. You can see it's invaded so deeply that it's causing bleeding. So this patient's bleeding, small amounts of blood's coming out of into their bowels. They didn't even know it. You can see this tumor is occupying the large amount of the lumen of the large intestine. Most colon cancers, the great majority, very rarely occur in the small bowel. Very, very rare. They always occur in the large intestine. And since we can use a colonoscopy to basically look at the rectum all the way up into the sigmoid, descending intestine, transverse, all the way back down into the right colon, the right ascending colon, you can actually visualize everything. And again, this is a rapid, easy to be done procedure. It was completely painless for me. I had no major issues at all. It was one of the more benign procedures I've ever really had. So again, to prevent this from happening, because this tumor is invading to the bowel wall, and on the other side of the bowel wall is your lymph nodes and blood vessels. Because colon cancer kills by spread like this, going all the way to the bowel wall in intestines, in the intestinal lymphatics, and then spreading directly up by venous flow into the liver. So liver is a primary source of spread with colon cancer, and then lungs and other areas of the body. So if you detect it early, what you would do is consider sending to one of our surgical colleagues who would then remove it. Okay, so colon cancer primary therapy, if caught early, would be surgical intervention. So if it's invading through the bowel wall but hasn't spread yet, what we call a Dukes B tumor, or a stage 1, early stage 2, you can resect it, put a special scope through the abdominal wall, which I'm sure some of the surgeons are going to tell you about, and you can actually then grab hold of the large bowel in front and in back, you resect it with a special scope, and then you staple it together with a really cool machine, and basically remove the cancer. You can remove a significant part of the large intestine without any major issues at all in people's ability to function, and it is curative. So again, screening procedures for colon cancer is important because you can intercede early with either a colonoscopy with a loop where you can just snag the polyp before it really turns a malignancy, or if it is a malignancy, go to surgery and have this done. Standard therapy in the United States for many, many years. So cancer prevention. We talked about screening. Well, how can you prevent cancer? If you're having, for example, carcinogenic chemicals, carcinogenic radiation, like ionizing radiation, what about cancer viruses or bacteria? What can you do? Let's talk about that. So we know that excessive sunlight, especially here in Denver, Colorado, with the amount of UV coming out of the clouds, which comes right through the clouds in a cloudy day, you think you're not getting it, but you are, even during the winter. You want to protect yourself from excessive sunlight. So using sunscreen works. SPF factor, at least 20, I prefer 50. A lot of people think 100 is overkill, but at least 20, and I think 50 is probably worthwhile to do. And putting it on nowadays, you can put it in moisturizers like I do. on my face. It also decreases sun damage for wrinkles, which most ladies really don't like very much. And using it on exposed areas of your skin, even during episodes like, for example, skiing in the mountains, because you're getting reflection from the clouds, right through the clouds, hitting the snow, reflecting up in your face, you're getting the double whammy for ultraviolet radiation exposure. So wearing it even in the mountains, even during the winter, is a good idea in Denver, Colorado. So preventing ionizing radiation exposure to the skin, including the epidermis and the melanosomes, is a good idea because it diminishes the risk of developing skin cancer later in life. So what about other things? Alcohol and tobacco increase the risk because they're carcinogens, by the way. Alcohol increases the risk of esophageal cancers, mouth cancer, stomach cancer. We know that for certain. And cigarettes increase the risk of cancer of the esophagus as well as other areas, including the lungs, bladder. I mean, again, there's a large amount of evidence showing even with stomach cancer increases the risk of cigarette smoking. So, but if you look here, that if you decrease alcohol consumption and decrease cigarette use, you basically can diminish the amount of cancer you might develop of esophagus. If you combine them together, you can increase your risk dramatically. Okay, so stopping them makes a difference. Okay, so 2 packs a day plus drinking alcoholic drinks increases the risk of developing colon cancer way too much. So again, decreased carcinogenic exposure would decrease the developing cancer risk as well. It makes sense. It's modifying your behavior. What about the fact that in the United States, if you saw on that world map, we have higher rates of colon cancer in the United States, and we think it's dietary. So if you look at, for example, evidence of correlation between meat consumption and colon cancer, and looking at the number of grams per person per day of meats, and people think primarily red meats, unfortunately. So our red meat consumption is pretty high, New Zealand even higher. So if you correlate that and see, directly it's associated with the number of cases per 100,000 people with colon cancer, and vice versa. So if you look at countries like Nigeria, Japan, Chile, where they modified the amount of meat in their diet, the more fish, more seafood, for example, and limit the amount of calories they have as well, that it diminishes the chance of colon cancer dramatically as well. Again, behavior changes regarding your diet do make a difference in the development of cancer, no doubt. So consuming fruits and vegetables. So if you look at people in Uganda, for example, at higher amounts of fruits and vegetables in their diet and versus what we have here, consuming fruits and vegetables appears to have an anti-cancer effect. Is it because of the fiber, or is it because there is an anti-cancer effect for antioxidants? We don't really know. The truth is, though, that people think antioxidants may be overplayed now, that the multivitamins that we are used to taking may not be effective if you're just taking a good diet, fruits and vegetables anyway. So in general, decreasing the amount of fat in your diet is a good idea because obese people don't do well for a lot of reasons, including the risk of COVID-19, which we're all being exposed to right now. And I'm sure we're going to have a lecture about that as well, too. So increasing fruits and vegetables, good idea for all of us. What about avoiding cancer viruses? For example, if we know that increased sexual contact associated with HPV, human papillomavirus, we know that women are affected with HPV have a much higher rate of getting cervical cancer later in life versus non-infected women. So increased sexual contact increases the rates of HPV, which is a sexually transmitted disease. So if HPV infection increases the risk of cervical cancer, diminishing sexual contact would also diminish the risk of HPV infection. And this is a direct avoidance, basically developing a cancer-associated virus. So is there a cancer epidemic? No. I mean, there's a myth at times that our cancer are reaching epidemic proportions. They're really not. Unfortunately, this year, because of the fact that people are not going to the doctor because of COVID-19 epidemic, there's actually shown that there's about a 40% decrease in the diagnosis of new cancers because we're not screening people as much because they're not coming back to the doctor. That's a problem because if we're not getting early cancers, we're going to see late cancers. That's something we may notice in the next 1 to 2 years. However, it's not an epidemic of cancer. That may be an issue regarding early screening and basically a lack of adequate access to healthcare providers. In a typical year, our cancer rates have actually kind of really steadied out really quite nicely. The only thing that has really changed, like I say, is more younger women are smoking before, and therefore there are women that are getting cancers in the 30s and 40s. I've seen them. Lung cancer can happen to women that smoke. So let's talk about some of the new techniques we're using in medicine And this lymphoma, for example. So this is one of my patients with lymphoma who had a bone marrow transplant, because unfortunately, some forms of lymphoma, of which there's different types, are not necessarily responsive initially to some forms of chemotherapy. We have to go on for more aggressive therapy, including what's called bone marrow transplant, what's called stem cells, giving them their own stem cells back to them, or having a relative, and giving them a brand new immune system so they can help eradicate their cancer. But if lymphoma is cancer to the lymph glands and we can't feel them and it's hard to see them, you actually evaluate it by doing different techniques. This is an example of a PET scan called positron emission tomography. So positron emission tomography uses radioactive glucose, sugar, that basically goes to any area that's rapidly and actively dividing comparison to their normal cells. So if our definition says that cancer cells that are neoplastic continues their cell division unregulated, that glucose will go to them because glucose feeds the cells. So we can see in the pre-therapy photo that, here's a patient, you can see those black dots going up and down the middle of the abdomen, and in the very center of the chest and up into the neck. These lymph nodes are contiguous. They basically connect to each other, and lymphoma spreads from one contiguous lymph node to another, across the diaphragm, up into the neck, down below the belly. I mean, there's the black spot directly below in the very lower portion of the picture is just glucose that's being eliminated through your bladder. That's completely normal. Okay, so the areas above in the very top of the picture are the patient's eyes. That's typical. It's not a big issue at all, and that's the bottom of the brain as well. Those are active neurologic tissues that do uptake sugar because that's what they do. But look at the post-therapy. So if we are effective, that means all the lymphoma would be gone. So using PET scans will tell us pre-therapy, post-therapy about how effective we really have been clinically if we cannot visualize areas of lymph nodes deep in the body easily, or if we can't feel them. And you can see in post-therapy, this patient had complete resolution. So you can see the patient when he turns around on the far right picture in the post-therapy, you're looking at his heart from behind. On the left-hand picture of post-therapy, you're looking at him from in front. So the picture is you're looking at the patient anterior posterior, which means you're looking at him from front to back. The two dots below his heart, that gray area of his heart in the center of his chest, off to the left, is his kidneys, completely normal. And the gray area directly above the right kidney, you can see, is the liver. So these are normal areas of uptake. And of course, the bladder is down below in the very lower portions of the picture. So these are the first PET scans that we started using in patients, where we were able to first look at areas of active cancer cells and how they're behaving up to about a resolution of about 5 millimeters. We started using our initial PET scans approximately 20 years ago, and then the technology has continued to improve. For example, here. So this is a three-dimensional image of a PET scan of a patient with lymphoma. Initial diagnosis of Hodgkin's disease, which is a kind of lymphoma. And what we did is we basically took pictures of the entire patient, and then we could be able to scan directly around them. And the bright area in the center of his chest is his heart rotating around. But the dots above are areas of contiguous lymph nodes, as well as a dot present in his right armpit, consistent with Hodgkin's disease spread. So this patient had stage 2 disease, okay, from the very center of his chest out into the armpits. He didn't have anything below the diaphragm. You can see his kidneys kind of glowing below his diaphragm. But a good example of the fact that now we're using three-dimensional techniques. We're combining it with CAT scans, which is computerized axial tomography using radiation, small little pieces of radiation, and they combine it into structural scan and then overlay it with a functional scan like the PET scan. So we actually using combination CT PET scan technology now. Again, the ability to enhance our capability of determination of cancer, response to therapy and treatment, and also initial diagnosis as well. Very common for patients with breast cancer upon diagnosis, depending on the disease stage, having a PET scan for evaluation of other organs. Let's talk about melanoma. Melanoma, skin cancer, has the fastest growing cancer probably in the world at this point. So we know it's one of the deadliest forms of skin cancer, and it only encompasses about 4% of all cancer patients, but it's responsible for the majority of skin cancer related deaths because of its high degree of spread. So it's not curable with surgery when it does spread, unfortunately, and it's pretty highly aggressive, unfortunately. So we have some recent advances. We're using now monoclonal antibodies. We're using more targeted therapy. It actually prolongs life. But the whole goal is getting melanoma skin cancers at early stages, because if you do surveillance, And if you know what to look for, there's certain warning signs that we can see that shows you if a melanoma is a brand new skin cancer or it's existing from an old mole that you had before in the past. We do know there are almost 2,000 melanoma skin cancers occur worldwide. Those numbers are continuously going up. And we can see that the incidence of malignant melanoma is on the rise because of increased sun exposure. Some people think that actually getting a tan is a good thing. It's the skin's response to damage is what that is. Okay, so unfortunately, around areas of the world where there's high amounts of sun exposure, like the equator, New Zealand, Australia, there are very high rates there, as we said before. And again, because of our height, because of our altitude here, that we have an increased risk of developing in Denver, Colorado as well. So we have in between 25 to 40 benign moles, benign skin lesions in our body. And if you can see here, here's a good example of a mole on a young lady's lip. It's rounded, it's nice, even features. It doesn't show any irregularity at all. This is a classic benign mole. The chance of it turning into melanoma is remote, but it can occasionally happen. If you look here on the left, that's what's called actinic keratosis. Again, benign. It does increase the risk of developing skin cancer because we do know that it's from skin damage over and over and over, the usage of ionizing radiation from the sun. You can see the scaliness associated with this. So benign versus atypical lesions. How do you make the difference? How do you determine that? So benign lesions are almost uniform in color. They're circular in shape usually. They're usually symmetrical bilaterally. If you cut a line right about in half, you look at one side versus another, they look about the same. Malignant melanomas diverge usually from that appearance, and we usually use the ABCDE criteria of nevus description. Again, nevus is a pigmented mole, and to determine if it's something we need to worry about, something that's changing, and something that needs to come off, or it's benign. So let's go over those ABCDE changes here real briefly, and I'll tell you what they are. So A stands for asymmetry. So if you look at this mole here, asymmetry refers to the degree of similarity when you compare one side versus another. So if you draw a line halfway down the middle of this thing, you can see it's asymmetric, that you cannot match one side versus another. This is an indication of some irregularity of growth. Okay, this would be an indication of asymmetry, and therefore we'd remove this. So removing melanoma at an early stage before it becomes invasive is curative by surgery alone, and it can be done as an outpatient very easily. So again, our dermatologists do that, our surgeons do it as well too. Very simple really to do. What about B for border? So the border refers to the degree of circular regularity of the edge of the pigmented lesion. So if it's perfectly circular, very rarely is it really malignant. So we look at very nice, even, round border. We like it to be nice and circular. What about C for color? So C for color stands for the degree of uniformity color that could be basically measured. So if you look at this lesion and look at it very, very carefully, it's got 4 different colors to it. It's got really darkly pigmented areas. It's got kind of pinkish areas, 2 different shades of brown. This is a classic example of a typical color. Again, the more colors present, the more likely the lesion is to be malignant. So it's a good idea to basically remove this lesion now before it becomes more invasive. So from the diameter standpoint for D, most pigmented lesions tend to be larger that are malignant than a pencil eraser. So, something that's got a large diameter, something that's got irregular borders as well too. It's not one of the more reliable criteria, but again, it's something we do pay attention to. E for evolving. So melanomas grow. Okay, remember the uncontrolled tumor growth of cells, and it's not regulated growth at all. So by their very nature, they tend to change over time, mostly increasing the size. So sometimes they do it in height. Sometimes they'll do it, of course, grow laterally into the skin areas as well too. If they're uncontrolled, they tend to produce asymmetry as an evolving mechanism. So it's something as a warning sign as well. You can see this lesion is asymmetrical, therefore it's coming off. So skin cancer screening really is effective for taking care of melanomas and finding them at early stages, including the slower kinds of cancers like squamous cell cancer and basal cell carcinomas. Again, those are radiation exposures to the sun as well too. It's just that they're so slow, it's very rare for one to kill you, but they can definitely cause disfigurement. So the procedure to take one of these things off is very simple. They can do it with local anesthesia now. And again, we're using the ABCDE criteria for looking at pigmented lesions primarily. So, and we're looking for a reason to trigger a biopsy. And again, a biopsy is removal. And not just biopsying it, just take a piece out, we're removing the entire thing if possible. So these are good examples of melanoma, real melanomas. You can see the upper left picture shows classic asymmetry, classic irregularity of the borders, classic variation in color. And actually this lesion is bleeding as well too, which is another warning sign because most moles never ever spontaneously bleed. The right upper picture, you can see is classic example of the fact that the lesion is actually circular, but you can see what we call serpentiginous borders. You can see the borders kind of wave up and down a bit, and the interior of the lesion is completely lost pigmentation, which is another warning sign, as well as the deep pigmentation located in the periphery as well. And that lesion is also melanoma. The lesion where you see in the left lower picture, as you can see above it, that the lesion initially was in a higher area, but it became apigmented. There's no pigmentation there at all, but the actual lesion of the melanoma is growing downwards now. So again, another melanoma with atypical growth, along with the central portion of the picture, the lower portion of the screen, and the right lower portion as well. So classic examples of melanoma. So we want to get melanomas early before they get to this stage, and we can. So thank you very much for the opportunity to deliver this lecture. Mr. Stirp will definitely be taking any questions. If you have any questions, he knows my email. More than happy to answer them for you. Cancer is a fascinating field. I've been involved in 35 years now, and it still continues to evolve, and it still continues to improve. So it actually has enhanced our capability to find cancers easier, effectively, more treating them, and it's as a multimodality type of therapy. It's one of the more rapidly growing technologies in the world. And again, thank you very much. Look forward to talking with you in the future.
Great job. Great job. So I learn something every time you speak, and I appreciate everything you've done for us over so many years. But, you know, the one thing that just scares me is the skin cancer for obvious reasons. You know, you and I lost a dear friend because of it. And that's the unfortunate thing that, you know, sun exposure. So.
Yes, indeed.
But I appreciate your time. I'm going to stop the recording, but it'll keep our Zoom going.